Welcome to this week's Brain Matters webinar. My name is Alex Reese, and I'll be your host for today's presentation. Our featured panelist today is Dr. Lina Chalak, who will be talking about the clinical management of neonatal asphyxia. Our industry partner for today's presentation will be Neuromonitoring. First, we'll review a few upcoming meetings and then get right into a recorded presentation from Dr. Chalak, followed by a short presentation by Neuromonitoring. At the end, we'll have a live question and answer session with our panelists, so please type in your questions using the Q&A tab on your screen anytime during the presentation. Now let's look at some upcoming meetings. All of these meetings are listed in the events section on our website, www.moberg.com. In June, we have the Neurotherapeutics Symposium with an all-star cast of international speakers. Then, later in June, the subarachnoid hemorrhage meeting, formerly vasospasm, is taking place in Amsterdam. Next is the neurotrauma meeting in Pittsburgh. At the same time, the International Conference on Spreading Depolarizations held by COSBID is taking place in Japan. The EEG Technologist meeting in Kansas City, followed by the ICP meeting in Leuven. We will be at all these meetings, and so we hope to see you all there. And now for a few abstract deadlines. Here are some upcoming deadlines, and while I won't read through them all, you can refer to the recording of this presentation, which will be uploaded to our website. To stay up on the latest developments in neuromonitoring, you can sign up for our newsletter, The Neuroscience Monitor. You and your colleagues can sign up anytime on our website. And if you have an event or news item related to neuromonitoring in the ICU, send us an email at info@moberg.com. Without further ado, I would like to introduce our featured speaker, Dr. Lina Chalak. This week's Brain Matters webinar brings us to the campus of UT Southwestern Medical Center in Dallas, Texas, where we caught up with Dr. Lina Chalak, who's one of the leading voices in the field of neonatal neuroprotection.
Good morning. My name is Lina Chalak. I am an associate professor here at UT Southwestern in the Department of Pediatrics, Neonatology, and I'm also the medical director of the Parkland NeuroNICU program across the hospitals on campus. We have a very large delivery system at Parkland with over 15,000 births, which makes it easy and fertile to study rare diseases such as HIE. And I've been here, therefore, for that reason, for about 20 years now on campus looking into neonatal HIE studies. And today I am very happy at the opportunity to talk to you about advancing outcomes in neonatal HIE. It's a field that has evolved a lot. And without further ado, we're going to move into the content and the objectives of this session. The objectives for today, when we talk about improving outcomes of neonatal asphyxia, is going to be discussing the pathophysiology, outcomes, and new therapies in the pipeline, as well as a review of the biomarkers, the importance of multimodal monitoring at the bedside. And I'm going to present to you some of the new ongoing studies for neonatal asphyxia, the Can Heal studies that are NIH sponsored that are going on right now on campus at UT Southwestern. I have no conflict to disclose. I am not getting paid to do this talk or to sell or recommend any products. This is really in the context of this educational series to highlight this information regarding the neonatal brain. And asphyxia is a terrible illness, really. It affects millions of infants worldwide. And according to recent WHO estimates, 1 million is left with disability each year, and another million will die from that disabling, devastating condition. And it all happens at the level of the interruption of placental blood flow sometime around the time of birth, leading to impaired cerebral blood flow and impaired gas exchange. The resulting low oxygen and low glucose in anaerobic environment is going to lead to low ATP. And this is not good for the communication of the neurovascular unit and the integrity of this structure. And what results is a cascade of excitotoxicity, apoptosis, necrosis, and cell death that really continues and has a life of its own even after you successfully resuscitate the infant. Now we understand this reperfusion phenomenon is what dictates the outcomes, and there is a limited therapeutic window to intervene. If you recognize early enough the infants that are at risk before they develop the secondary energy failure, and you attempt to treat them with therapeutic interventions, there is a chance potentially to modify this cascade of events. When it comes to treatment of the newborn with asphyxia, for a long period of time, we really thought that there was no therapies except supportive care. In fact, when I was in training, we were told to treat the seizures and to support the infants, and that was about it. And we have come a long way since then. So I was fortunate to work on a field that has moved so much in the past 20 years or so. And now we understand that we recognize these infants after they're born with a distinct encephalopathy that was beautifully summarized by Dr. Sarnat and his wife in the 70s. And it was the infants that have moderate and severe encephalopathy after birth, stage 2 or 3, that have the worst outcomes. This evaluation was based on serial detailed EEG testing and neurodevelopmental and neuroexamination testing in that first week of life. The issue is we know that to be able to intervene, you need to recognize these infants within 6 hours. So we had to find alternative ways to recognize the high-risk infants. So we screened them based on presence of fetal acidosis in the cord blood, an acute perinatal event, and we simplified the exam to a modified Sarnat score using 6 categories that are simple to describe immediately after birth. We have come a long way using this screening method from the first reports where infants were immersed in buckets of ice in the 60s, and reports came of less mortality, to wonderful studies in animals first and then in humans, explaining to us that hypothermia actually works in the context of HIE because it works on the acute and subacute phase, and it affects all these highlighted processes of free radicals, mitochondrial damage, apoptosis, inflammation, multiple effects at the molecular level. The bottom line is it decreases your cerebral blood flow, your metabolic energy demand, your consumption, and it slows down that whole reperfusion phenomenon, giving the body the chance to self-heal. These studies were confirmed, and we now know beyond any doubt that unlike any hypothermia in any other model, that when you apply hypothermia in the first 6 hours after an asphyxial insult, you've got actually even better result than these other models because you know the time of your insult. So not only you reduce death, but you also reduce disability. As you see in this meta-analysis, the number needed to treat are 1 to 6, and it's a 25% relative risk reduction. So we're able to tip that balance. Our odds are still about 45% for disability and death, but that is much better than the prior odds where the majority would either die or have disability. And for once, these early trials proved that if you intervene early enough, you could make a difference in this disease and you could modify outcomes. And now that we've proved that, we want to do better than the 50-50. Can we further tip that balance in our favor and get the majority of these infants to have good outcomes? going to discuss with you multiple strategies. We and others are attempting to do that. The first one was the more of something is better. In the Neonatal Research Network, where we are active participants since the 80s, have attempted this study where longer and deeper cooling was tried. And the study was published in JAMA the last year. The short and the long-term outcome showed that it doesn't give you more benefits. So, and then potentially when you cool to the very low degrees, 32 and below, you can get into some potential side effects. The converse was also shown that higher temperature after an asphyxial insult is actually very deleterious. So maybe more cooling is not necessarily more helpful, but regulating and avoiding hyperthermia is definitely beneficial. As you see in these animal histopathology slides, even less than 30-minute exposure to a high temperature increases substantially the injury on the brain. And these were confirmed also with NICHD and the TOBI in multiple trials that showed that for the controlled non-cooled arms, even each 1 degree Celsius above a normal temperature was associated clinically with 4-time odds of death and disability. So what these studies tell us is that the same way you maintain a neutral temperature zone in a healthy baby, you need to keep a tight control of your temperature in an HIE baby. And the ideal range is 33 to 34 degrees Celsius, and you need to continuously monitor it. And doing more of something is not going to get us better results. And if we know that hypothermia works best in this context, then how about the strategy of combination where we add something else to hypothermia? And multiple drugs are being considered. Xenon gas have been extensively studied by our colleagues in the UK, Dr. Thoresen, Dr. Edwards. The availability and the expenses and the timing of administration have been a hassle. Our colleagues in Duke, Dr. Cotton, are looking into infusion of autologous cord blood cells, and the results are also very promising. Multiple other pathways are being investigated, but I highlighted in red erythropoietin because it is really the front runner as far as we're already in advanced phase 3, almost 75% to completion. And so this is really the front runner when it comes to combining something with hypothermia. And the HEAL study is that large phase 3 trial with over 15 centers participating, led by Yvonne Wu and Sunny Jewel. And here we are as one of the participating centers too. And the beauty of the high-dose erythropoietin is you give it intermittently for 5 days with hypothermia, but it doesn't just work on the acute and subacute phase like hypothermia does. It also works on the chronic phase because we do know that erythropoietin can affect angiogenesis and neurogenesis and neuronal repair and sprouting. So it is very promising as an add-on therapy to get us further to tip the balance and to further improve the outcomes of these infants. The third and last strategy I want to discuss with you is something very important. We originally caught the tip of the iceberg with the sickest of these infants, but there are more population and more patients being affected under the tip of the iceberg. And there are multiple ways to get at those. One way would be, how about those that make it 6 hours and a half into a transport center? Would it be too late to cool them? Or those that had a seizure at 8 hours when before they were not sick. And the NICHD late hypothermia study that we at our center participated in as part of the Neonatal Research Network showed us that actually, yes, you can make a benefit, although not as important or as impactful as when you do if you intervene earlier, but it's better than not doing anything. Similarly, the almost term babies, the 33 to 35 weeks, again, these studies are almost completed, and we should be able to tell very soon what best to do regarding the evidence of these infants. The most difficult has been the infants with lesser encephalopathy or milder encephalopathy because they represent the majority of these infants under the tip of the iceberg. The big issue is, how do we define these infants early on without the first 6 hours? And how do we recognize them? And this is something I've been very keen and interested in studying. And a lot of the world is interested in those babies too. Registry databases do show us that there is a drift in our existing protocols. 40% of the babies that we're cooling are mild. In Australia, a quarter of those that are cooled are mild. What's common to all of these registries is that they don't look beyond hospital discharge at the outcomes. So they're cooling, but they're not telling us how these babies are doing. And they're not really defining what they considered mild HIE in the first 6 hours, because really this is not the purpose of these registries. This really has led into the PRIME study that I have done and that just got published. You see here on the January issue of the Pediatric Research. It took the front cover, and I'm going to talk you a little bit about the key findings of that study. It was a collaborative work with multiple centers. Canada was a very important, McGill was a very important center with the recruitment, and as well as UK, Thailand, other centers with the network and colleagues. And when we started the study, it was based on the fact that we needed data on these infants, and we didn't have any funding, but we decided to proceed, each center at their own expense, with looking into what happens to these infants. We used the same enrollment criteria of they had to have evidence of fetal acidosis, but since we had no consensus and there was lots of challenges on the early examination in the first 6 hours, as you see, lots of overlapping categories. Infants don't stay into one category and say, oh, I'm mild all the way. They overlap. There is lots of effect of sedation, anesthesia, resuscitation, and to avoid missing any of potential infants that we needed to be having a broad inclusion criteria. And so what we did is we used the same examination form with the modified Sarnat score, but we considered anybody who did not have a normal exam and who did not meet criteria for cooling under this broad definition of mild encephalopathy. And we tracked them with serial examination in the first 6 hours and daily until discharge. And although the majorities were improving, one infant did have seizures after 6 hours. The rest were improving, although 40% did have abnormalities close to discharge time. And we found that both the early and the late discharge examinations were associated with disability later at 2 years, as you will see when you get into the detail of that paper. A lot of these infants had short-term outcomes that were abnormal on the exam, on MRI, on amplitude EEG. But what was the most concerning was what we found regarding 16% meeting the NICHD criteria for disability using a cognitive Bailey 3 under 85 and or presence of a CP and or deafness or hearing or visual impairment. An even broader number, 40%, had any Bailey score be under 85, and that was mostly language Bailey scores that were abnormal. Lesser infant, thankfully, had 2 standard deviation below the means, and very few had CP and autism. But if you think about it, that raises the whole issue of it was definitively more than we expected when we started all this, and we followed these infants prospectively. And these numbers were concerning enough that we needed to do something about this patient population. The subject of mild encephalopathy, and is it really mild, has really taken a lot of subject of interest and debate. And I was asked to edit a whole issue for the early human development that I would refer you to, where wonderful colleagues have helped me write recommendation and review of the literature regarding MRI, long-term outcomes, new therapies in the pipelines, and biomarkers. And it's a comprehensive take on how complex the issue of infants with mild HIE it is, and how best to manage these babies and what to do with them. But what that takes us is that is it really mild? Do we call it, is it a misnomer to even call it mild? And how do we define those at risk so that we don't subject those that do not need therapy to unnecessary treatments? And really, the bottom line is we need to better stratify this illness. And that takes me to the second part of the talk, where I really think rethinking our risk stratification is what is needed. Really, in the past, we've focused on those infants with the most severe encephalopathy, and we've drawn the line with right here. The bottom line is, if we rethink our data, the infants who have acidemia and no encephalopathy are going to do well without any neuroprotection. The infants with severe, we're barely improving, if anything. They're too severe to help. The bottom line is we need to focus on those that lay in between and how best to differentiate those that need help and treatment within that group. And what is the best biomarker to identify those at risk? If we think about the encephalopathy, the biggest challenge is it's a dynamic process. So if you limit yourself to right at the time of birth, whether you're doing an exam or an EEG or any other spot check, you could miss the acute on chronic, the prenatal. These insults are evolving minute to minute, and you need a dynamic way to track it. The most established biomarker is the MRI, and we know that infants that have basal ganglia or watershed insults are associated with injury and abnormal outcomes. The time of the MRI becomes important also, and the best yield of the MRI. But really, spectroscopy is the most sensitive predictor. If you do it early enough, you're going to see the lactate peak, and that indicates that a reperfusion injury has already happened in these infants. Acute obstetrical biomarkers also tells us a lot. This is one of our study at Parkland, where we had over 85,000 deliveries in a few-year period. And if you see markers like abruption, ruptured uterus, cord prolapse, that increases 100-fold and more your odds of needing hypothermia and having death and disability at 2 years despite hypothermia. So this indicates a very severe insult, as we published in 2014. I always like to talk about the placenta because it's an orphan organ and it should never be sent out to the trash can. It needs to be sent out for studies. And that's what we do at Parkland. Anytime there is a need for resuscitation, we send out placental cultures and placental morphology studies. And what we found was that inflammation, chronic inflammation like velitis specifically and chorioamnionitis, increased the odds ratio of abnormal outcomes and of needing hypothermia to 9 times higher, and actually have very good positive predictive value. The problem is you don't have the placental results until a week after the insult, and by that time, it's too late to intervene. So that leaves us to rely a lot on EEG because it gives you trends, whether it's amplitude EEG or real-time EEG. Amplitude EEG is better for trend recording, and these burst suppression, low voltage, and flat tracings have definitively been associated with abnormal outcomes. Similarly with the NIRS, we don't use it for absolute values, but we do know it's a proxy of cerebral perfusion and blood flow, and therefore you don't want too high because that's a reperfusion insult if your numbers are very high, but you don't want too low either because it means your brain is not getting enough perfusion at all. And so we can use it to titrate also a severe insult. If you think, however, of all those biomarkers that are established that we use and their value in the spectrum of encephalopathy, you will notice that what I've showed you really helps you narrow down the most severe cases and helps with prognosis. It doesn't really help us where the most help is needed, which is the lesser and the most subtle type of insults. And for that, we really need to turn our attention to alternate ways of biomarkers and a different kind of biomarkers altogether. And what we're interested in is the interplay of how cerebral blood flow affects cerebral function, how the integrity of this neurovascular unit is affected without doing invasive things so that we can track it dynamically. This has been really my area of research over the last 10 years or so, getting above the clavicles non-invasively. Started with studies related to hypothermia and rewarming, and really came down to the conclusion that if you do not integrate all your devices at the bedside, and if you don't have a real way to track down this information, it is very hard to just use each information you get from your blood pressure or from your NIRS or from your EEG monitor in a way that makes sense. And this is what I would love to share with you in the last part of the presentation. This is actually one of the early patients that I did recordings on. That infant had mild encephalopathy. And you see here the arterial blood pressure recording. Once you download it over the duration of hypothermia, luckily for us, all these infants have these oscillations. Their natural oscillation, their variation in blood pressure, it is not induced by medication or by disease. This infant was very stable, was not on any medication, was on room air. And it's actually beautiful because unlike other diseases, we don't need to induce changes. Changes are already naturally happening. We can look at the effect of these changes of arterial blood pressure on cerebral blood flow and how that affects the brain and whether it's associated with injury or not. What's even more fascinating is it's not just the blood pressure. If you think about it, every single function that we do, whether it's blood flow, oxygenation index, blood pressure, CO2, brain EEG waves, everything oscillates. And everything oscillates at a different frequency and a different rhythm. And rather than thinking that this is just noise and unrelated, we need to find a way to make that signal make sense. And if you try the conservative, conventional way, which is we have, for example, blood pressure that oscillates, and we have a proxy of cerebral blood flow, whether it's NIRS or whether it's Dopplers, technically it should not change if the infant has an intact autoregulation. But if an infant does not have an intact autoregulation, you're going to see that they fluctuate. And the convention or consensus is you average that data in over whatever duration of time, like in our case, it's 3 days of hypothermia and rewarming or reperfusion injury where the infant is at risk. The problem with that approach is we discovered that when you do the averaging with different time interval, the time scale makes a big difference on the result. It's not mirror image by definition. These are complex signals and they're different types of oscillation. And you cannot capture them with a standard time domain analysis. Another way of doing it would be the frequency analysis, where you focus on the frequency of the oscillation, and the high yield is these very low frequencies that I've highlighted here for you, that my colleagues also at UT Southwestern have investigated and narrowed down, and I work with Dr. Zhang quite closely. And the issue with these are perfect measurements for short, brief, optimal recording and linear models. But with HIE, we're not doing 5 seconds or 5 minutes of recording. We're doing 3 days of recording. So you really do not capture the complexity of the signal. And what I soon discovered is that there are roadblocks to study this disease and to be able to make advances. And the biggest was the need of real-time physiological markers, of course, for staging and looking at the severity of this illness. The hemodynamics are nonlinear and they're varying, and our methodology is really a trade-off. You either focus on time and you can have a good resolution over a long period of time, or on a specific frequency range. And most frustrating, there is lack of an integrated multimodal methods to look at both complex signals over time and long periods and multiple frequencies of duration. So I did realize at that point that I needed to collaborate with other people from different fields, and I needed to look at what things beyond medicine have looked at. And the best analogy of a natural catastrophe that would be the proxy for birth asphyxia would be a hurricane or a tornado. And for this mathematical tools, our colleagues and mathematicians use Wavelet. And the best thing about it is provides good resolution for time and frequency. So I wanted to see how we can adapt this to neonatal brain health. And the best aspect of it, like I said, it gives you a good resolution of both a long period of time as well as the whole spectrum of frequencies that you're interested in. Just the way the MOLIT wavelet signal is, it doesn't make assumption about a stable signal, non-changing, or linear signal. It uses different mathematical equations. And I collaborated with bioengineers at UT Arlington and with other researchers here on campus with adult neurophysiology experts to figure out the best way to create my own neurovascular bundle at the bedside. And this is one of our babies getting recordings. The idea is translate information from multiple modalities, irrespective of which machine you're using for NIRS, or which machine you're using for EEG, or which machine you're using to get your blood pressure recording. Get them all integrated so that the wavelet can analyze whatever physiological information you're interested in, like cerebral autoregulation and neurovascular coupling, and find a way to get that information back at the bedside. This is an example. It's not just a beautiful configuration. It tells you the exact time where you have a high coherence, where the signals show impaired autoregulation or neurovascular coupling. It tells you the exact frequency where that signal is occurring, the time where it's occurring, the strength of that signal, and it can be numerically computed. And it gives you also complex signals. So you can be 90 degrees opposite, or you can have 180 degree opposite. It can catch these complex signals. They don't have to be exactly happening at the same time scale. And we pilot tested this concept, and we were very happy to find that when you combine all these metrics from the wavelet, it gives you an 88.9% accuracy compared to our usual other estimates. So these results were very promising. And actually, I even advanced this whole concept a little further by looking into not just cerebral autoregulation, but also proxies of cerebral blood flow and proxies of EEGs, and looking at neurovascular coupling with these advanced methodology. And we were able, again, to show that you can differentiate between the infants that have 2 years abnormal outcomes and the normal infants that have high neurovascular coupling when you apply this methodology. These results were very promising, and they really show that this concept of the neurovascular bundle at the bedside can provide dynamic, non-invasive measures of autoregulation and neurovascular coupling, and have the potential to impact risk stratification, therapeutic decision-making, and prediction of outcomes after birth. The issue is these were small studies, and they needed to be validated in larger populations. And I was lucky enough that I got funding from the NINDS for my cerebral autoregulation and neuromonitoring in asphyxia to sort out these infants with mild and moderate and severe HIE early on, and also as an add-on secondary study to the HEAL to look into the responses of therapies in real time during the neurovascular monitoring. And these CAN HEAL studies are going on right now at UT Southwestern. I'm about year 2 out of 3 of enrollment. I still have to follow up these infants. The CAN HEAL study will finish in 21 or 22, and it will provide us with about 100 infants with this methodology. And we're working very, very closely to translate this methodology so it doesn't need a bunch of bioengineering helping me read and translate the beautiful signal into numbers so that it can be done at the bedside by any physician. And while in the coming few years we're doing all that, the hope is with all these multimodalities of oscillations that are happening in the newborn brain, instead of just hearing the noise, we would be able to hear the exact signals that the neurovascular unit is trying to tell us about how severe the disease is, if it was impaired a little bit, how it's responding to therapy. And perhaps we don't need to treat all the babies the same way. Perhaps there is a different treatment for every different baby, depending on the signal that you get from each infant. And I think that's where the future of new therapies for HIE is going. I really am thankful for the opportunity to present this work in progress, and I hope that in the coming few years we can have more answers. I'm thankful for the grant support because none of it can happen, and it takes lots of collaborative work, and I have lots of a multidisciplinary team of collaborators that help me. And I'm really thankful for Dick Moberg and the team for always facilitating the integrative methodology to help gather these signals and to help promote the importance of these signals in such a teaching seminar as the one we have done today. And I'm really happy to answer any questions. And I hope that I didn't confuse you and I gave you some idea of where things are going with this complex disease right now. Thank you.
Thank you, Dr. Chalak, for such a terrific presentation. And at first glance, it actually looks like Dr. Chalak's broken the attendance record for our webinar series. So I know there's a lot of enthusiasm for this particular topic. And so what I'd like you all to do when you're watching at home is take this moment to prepare your questions using the Q&A tab on your screen. While we're getting ready for the Q&A, we have a short industry partner spotlight with our partner, Nanan.
Anesthesiologists and perfusionists depend on monitoring equipment to inform critical care decisions. Knowing patients' cerebral, tissue, and systemic oxygenation levels can make an important difference during long and complex procedures. But several factors can affect the accuracy and reliability of cerebral and tissue oximetry measurements. For example, sensors may not be optimized for accuracy with monitoring systems. Readings may be distorted by extraneous tissue or ambient light. Inconsistent measurements create doubt and interrupt workflow. Equipment may not account for variations in skin pigmentation. In complex surgeries, equipment limitations or failures can have serious consequences. Desaturation events are correlated with increased risk of several adverse effects within 6 months after the procedure. These range from longer ICU stays to diminished cognitive function to stroke and even death. Reliable monitoring equipment helps clinicians manage these risks. Cerebral and tissue oximetry measures oxygenation of the brain and other tissues. Also known as regional oximetry, or RSO2, it gives perfusionists valuable patient status information. The SenSmart X100 system from Nanan Medical provides quick RSO2 readings and reliable monitoring so clinicians can concentrate on what matters most, patient care. Nanan's SenSmart technology uses 2 emitters and 2 detectors in each RSO2 sensor, along with patented algorithms to create light paths through surface tissue and the cerebral cortex. This monitoring system provides accurate, consistent measurements of tissue oxygen saturation for real-time management of patients at risk for compromised oxygen saturation to the brain and other tissues. Readings are fast and reliable, even for patients with dark skin, low perfusion, or challenging health conditions. Used with compatible RSO2 and SpO2 sensors, the SenSmart X100 can monitor up to 6 cerebral or other tissue sites on adult, pediatric, or neonate patients. It can be used for spot checking or continuous monitoring of neonatal, pediatric, or adult patients in hospitals, long-term care, medical facilities, sleep laboratories, subacute environments, and patient transport. It delivers consistent, reliable cerebral and tissue oximetry measurements for patients of all ages. The SenSmart X100 is now integrated with the Moberg monitor to allow for simultaneous monitoring of your most critical patients. To learn more about the SenSmart X100 Universal Oximetry System, visit nonin.com.
So once again, everybody please send in your questions, and we will now go live to Dr. Chalak in Dallas, Texas for our Q&A session.
Hello, can you guys hear me?
Dr. Chalak, we got you.
All right, excellent. Thank you so much for the participants. And I see there is lots of excellent questions already that have started to come my way. I'm looking at the Q&A section, and I'm going to go in the order they were received. Does it sound good, Ryan? Okay. So, Alex, I'm going to go ahead then and get started with the questions. The first question we have is, in your experience, how does NIRS monitoring affect your treatment decision for baby with HIE? And really, to me right now, we are using NIRS. We started when a baby is born with HIE that we identify after we do the exam. We get the lines placed, we get the baby on hypothermia. And I look at the trends. And like I mentioned in the talk, it helps me identify those with the most severe. If the NIRS is reading 95, that's the maximum, depending on the sensor, what's the maximum that the sensor can read, it means that there is a reperfusion injury going on, and it usually indicates the severity of the prognosis. So I use it to avoid hyperoxia. If a baby is on 100%, I try to wean that. So it kind of helps me know how to categorize the baby and the progression overall. Based on trends. And we're using it now on more research to try to get more information regarding real-time monitoring of beyond just NIRS, as was presented. Let's see. The next question is, what do you think of the blood biomarkers over time? Are they useful, and which one? So we're going to answer again live on that one. Really, I haven't had the time to talk specifically about each one of the blood biomarkers, but we and others have done lots of research on that. Interleukin-6 and GFAP, glial fibrillary protein, are very useful in the first 6 to 24 hours after birth. They peak around 24 hours. So again, they're more used for research purposes right now, since there is no real-time assay that will give you the results to guide and base your treatment algorithm on. But that hopefully should be coming also in the pipeline, and that's a very important question. Okay, let's see what comes next. Dr. Liu is asking, nice data about the decreased neurovascular coupling in the abnormal babies. The question is about the main frequency is even lower than the frequency reported for cerebral autoregulation. Can you explain why? And really here, it's an interesting observation. When we're doing the data with the wavelet, you keep in mind that you can study the lowest frequency depending on the machines that can sample the lowest frequency. So it's not machine specific or sensitive. A lot of the prior studies on cerebral autoregulation had focused on the 0.01 range. The ability to focus on the lower frequencies allowed us to show this data. It goes along with adult data on memory and connectivity that shows that the lowest frequency is where these global network processes and communications are going on. I think the key is to replicate that data in larger samples and to make sure that we're measuring both cerebral autoregulation and neurovascular coupling with the similar frequency spectrum, the whole spectrum, and that's what the wavelet allows us to do. So it's a very good research question for those of us who are doing research in this field, and we're doing those studies right now.
The next question is by Pusti Orujova, who is asking about the use of erythropoietin and hypothermia together. And Pusti, you're absolutely right. This is what the HEAL study right now is trying to confirm. So the HEAL is the study led by Yvonne Wu and Sunny Jewel, and that we participate in currently. The enrollment is at 75% or more. It should be the largest study to date. And infants are randomized to either receive hypothermia or to receive both, a combination of erythropoietin and hypothermia. And hopefully in the coming year, the results would be published and we'll be able to answer that questions most definitively regarding the 2-year outcomes of these infants. So very, very promising question and area of research, and hopefully the answer once that trial, the HEAL trial, is finalized, should be coming very soon. I hope I've answered that question appropriately. Let's see. We have another question by Jean Gardner-Amore about a 34-weeker infant, 34 weeks and 3 days. And the mom had been treated with magnesium, abruption, heart rate deceleration. There were lots of concerns around the time of delivery, and passive cooling was initiated. And then the infant was colder than usual. And what are the risks associated with cooling an infant who does not require treatment? So it's a beautiful question because it illustrates two important phenomena. First is very important, the preterm infants, and we do not know whether it's safe to cool them or not. So we have an NICHD study right now that is also finishing enrollment this year that we're participating in, where we're looking at the infants that are born between 33 and 35 weeks and randomizing them to therapy or no therapy to make sure that the adverse effects are not more than the benefits. In this particular case, a preterm infant is more likely to get cold. And so we're not confident 100% that the best thing to do for these infants is to cool them. We are hoping that the benefit will outweigh the side effect, and that study will confirm these questions for us. Because remember, all the randomized trials have involved infants 35 and 36 weekers and above. So the benefit of cooling a 33 and a 34 weeker has not been proven, and we're trying to get those answers right now. I would say until we get those results, I would really be very careful about that. The second thing that the question is about is the danger of cooling somebody who does not need any therapy. I think that allows me to address the issue of the passive cooling. If you're not monitoring your continuously your temperature, there is always the risk of overshooting with your cooling. And then when you get too cold, there can be potential complications from bradycardia to a worsening of the pulmonary hypertension to potentially more risk of coagulopathy. Because remember, the range tested and shown to be safe is the 33.5 or between 33 and 34. If you have a baby who's severely affected and you're doing passive cooling and you're not continuously measuring that temperature and the temperature drops to 33 or 32, you're going to be seeing more of the side effects. And so I would caution about the urgent need to do continuous temperature measurements for the babies that we are providing hypothermia for, and to try to stay in that target range, like devices like Decatherm or any other device that continuously record the temperature while you're cooling on transport will allow you to get away with these side effects, from these side effects. The preterm part is ongoing study, so we need to wait for that study to be finished to get the conclusive answer on the 33 and 34 weekers. But that was a double excellent question here. John Baxter has the next question, and he is interested in the novel weather modeling techniques to the neuromonitoring field. I agree, this is something that I got into it based on need. none of the available methodologies was allowing us to answer the question of the time, monitoring over long periods of time, 2-3 days, and monitoring over all the range of frequencies. So we had to get to work with bioengineers and work with methodology that is precise enough to allow recording of a whole range of frequency and a whole range of duration for these very sick babies. It's not a matter of 5-minute recording and then we're done. Thank you, John, for your question. Okay, the questions are continuing to be coming. Let's see. We have one attendee who is asking about, do we worry about microthrombi and monitoring for those? There is always the worry on a coagulopathic sick baby with HIE, whether you're cooling them or not. I personally like to get a head ultrasound before I start cooling those infants. It gives me a baseline, whether an infant had a stroke or a thrombus. And this way, then, rather than to say it's something related to the therapy, then it's something related to the disease itself. I myself do not do PT, PTT as part of the protocol for babies with HIE. I go clinically. If they're bleeding, I give them FFPs or platelets, or I monitor those. If they're not, then I don't do it. Some centers do monitor PT and PTT daily in the first 3 days of life, but I don't think the incidence is so high. And I think clinically babies will show if they're having a bleeding or a coagulopathy tendency. Let's see, what is the next question? Kula is a nurse from a low-income country, asking a question about low-income country about what do we do if we do not have the facility for cooling. This is an excellent question. I know the group in the UK, led by Dr. Sudhin Tayal, has been working with low-income country options for cooling. I know there are options for using a fan for cooling. Some of these trials are published, some are still ongoing. The group in the UK is finishing a study for cooling in the low-income countries. And even if you don't have the facility, there might be kind of like a made options. The cooling blanket is available for adults. It can be, the adult blanket can be utilized. I would refer you to the published articles on the topic and to the UK group. I'm happy to send the link when I type my answer later for that. Okay, Dr. Liu is asking a question about the relationship between the neurovascular coupling and cerebral autoregulation. This is a good point. With the CAN-HEAL studies right now, where I'm trying to answer those two done simultaneously, I think from my pilot preliminary data, it looks like they provide, not all the babies that have problem with cerebral autoregulation are going to have problems with neurovascular coupling. So I think it provides a complementary relationship and opportunity to study different mechanisms. Not all the babies that have abnormality in one, based on our preliminary data, are going to have abnormality in the other one. And it allows us to target therapies in a precision way in the future, specific to what deficit or problem the baby seems to be having, and hopefully to answer them and to see how the baby is responding to that therapy in real time, since it's not a simultaneous yes or no phenomenon for these both for these two physiologies. So again, an excellent question. I love that we're getting both research and clinical questions. So I'm going to do my best to finish all of them. Let's see. We have another question by one of the attendees. I don't have the name. It is asking about other biomarkers like lactate or troponin for those mild babies. And I think these are excellent questions. In the comprehensive review article that I list in the early human development and in the pediatric research current opinion, again, that were published this year, we mention about those. They're still research based, I think an elevated lactate would certainly be of concern. A lot of the mild babies might not have it though, but I definitely think lactate and troponin are useful. I currently use them in my clinical protocol, so I didn't have the chance to talk about that. But for babies with HIE, you want to evaluate their liver enzymes, their kidney functions, troponin, lactate, to be able to evaluate the different extent of injury on these different organs. Remember, asphyxia or HIE is not just a problem to the brain. It affects multiple other organs. So it's different than traumatic brain injury or other adult disease in that, by definition, your other organs must have been affected because your brain is your last to be affected based on the whole concept of cerebral autoregulation. So it's important to monitor those when you are evaluating an infant with HIE, whether it's mild, moderate, or severe. Okay, then we have another research question about hypothermia and cardiac arrest. The infants with low intracranial pressure, cooling to different degrees, and basically the measurements of intracranial pressure. I think it's a fascinating question. Unfortunately, with babies with birth asphyxia, we do not measure intracranial pressure directly because unlike traumatic brain injury or cardiac arrest, we do not have the devices to measure intracranial pressure directly. So we use Doppler or NIRS as a proxy of your cerebral blood flow. It would be wonderful if we had a non-invasive way to look at intracranial pressure to be able to answer more of how that is affected by cooling and by asphyxia. So more hopefully on devices development and future research studies in that field. Okay, we have a very interesting question. It is, what do I think about hypothermia? Is it uncomfortable for babies? And also, what do we think about stem cell therapy? So both are excellent questions. I think it depends on the babies. We have found a way to position the baby on the blanket where most of our babies are not requiring sedation. Problem with sedation is its effect on the developing brain or vulnerable brain with asphyxia. You want to make sure that you're doing sedation to those who need sedation. If somebody's comfortable and is not needing sedation, is not irritable or crying, then half of the babies do not need it. And the other question is about stem cell therapy. The group at Duke is studying this, and it looks very promising. And hopefully it will allow us to further improve the outcomes of these infants. Again, it's still research-based right now, and we do not have the final word on that. I think we have managed just in time to answer all of the questions. They were excellent questions. Thank you guys very much, and looking forward to more development on this field.
Thank you very much, Dr. Chalak, for taking time out of your Friday to be with us and to answer everybody's questions.
My pleasure.
Hey, thank you again.
Okay. Bye.
So as we wrap up our Q&A session for the day, I'd like to invite everybody to send us any topics for future webinars to info@moberg.com. And furthermore, if you have an interest in enrolling, or I should say, adding yourself to our communications via the Neuroscience Monitor, we have a newsletter that we'd like to share with you all as well, which will also allow you to stay current on developments in the field and future webinars as well. So thank you again for everybody who attended and took time out of their day in the U.S. As well as abroad. Thank you all for being with us, and we look forward to seeing you next time.